Hey guys, I got a couple questions in clinic today about locators, how to pick them up. Maybe you haven't had a chance to do that in dental school, so this is maybe a 5-minute introduction on how to pick up locators. Locators have been around a long time because they work, they don't take up a lot of space, and they clinically are very easy to manage. So you have your here's different sizes, your tool to seat them and remove them. This is the different inserts. Here's your actual abutment that screws onto the implant, cuff height, and then the cuff height would generally correspond with your tissue depth, and then on top of that you have enough titanium to accept the retentive element. You have two different kinds here. This one has a plunger in the middle, and that one is the regular kind. These have no plunger in the middle. They're called extended range and can accommodate more divergence in the implants. So when you order these, or when you pick these out, select one that is the same height as your tissue depth. So if your tissue from the top of the implant to the crest of the tissue is 2 millimeters, you would order a 2 millimeter locator, and it has enough above the tissue, like the locator is not literally 2 millimeters, it's 2 millimeters to the top of the tissue plus enough to accept the retentive element. If your implants are within 10 degrees, you can use the regular type of attachment, and if they're within 20 degrees each, that's 40 degrees total. I find 40 is a lot. You really stick more with 30 if you don't want a lot of issues with the housing elements. They get rubbed and they get worn out if there's too much divergence. So if this is nice because it has retention on the inside in the plunger area and around the outside on the rim, and this one just has the retention on the outside on the rim. So you can mix and match. You can have two of these and that are straight, and then one that's got a little angle to it, and you could have an extended range element on that one. Here's an old set of pictures that I picked up from the internet, from the locator site. So here's the healing abutment being removed, and I'm sorry about the background noise. I'm just in the office and got people over for the kids are having lunch. But the healing abutment is removed, and then you can select the appropriate size locator. Here you have the abutment itself and what I call the housing or the metal keeper, the retentive elements, and this white ring is to block out underneath the locator abutment so that you don't lock it on when you pick it up. Locator tool has changed a little bit now. This is the old kind, so I'll show you that in a minute. So you put the locator abutment on. There is a driver that comes on the end of the tool, and one side fits the locator abutment that has a kind of a triangle in it. The other side accepts an 050 hex wrench. You can use that to torque the abutment down. And there's the 050, and there's the triangle locator driver. Miss Pat keeps that in the sterilization area typically. You want to make sure that your denture fits passively. Basically what you want to do is you want to relieve the denture so that it sits down over the locators in the mouth, the locators and the attachment housing on top of that. If you didn't, let's say you had one that was too tall or the denture was hitting this one implant, then you might be overloading that implant. You're not getting good tissue support from the rest of the prosthesis. What I do is I take a little bite registration material, mix it up on the pad. I don't even use the tip, saving 50 cents. So I just squirt out a little, mix it with a spatula, put it inside the denture, seat that patient in the denture's mouth. Then when I pull it out and look at it, I can see the 4 spots where the 4 locators are. Mark that with a pencil, and take an acrylic burr and open those 4 areas so that it will sit down over the locators and the keepers. Once I have that in place, I can then refine that by putting another wash of bite registration material in there. And then if there's a spot where the keeper is hitting the denture, then I can mark that, relieve it with the acrylic burr. When we're done, we want to make sure there's a very passive, non-interference fit. The denture's not hitting the keeper or the implant anywhere, and it's seated only on the tissue. And you can tell that clinically because you put it in and you push down and you can feel it settling into the tissue. It's not a metal to plastic hit. And the tissue moves a millimeter, right? So you feel that displace into the tissue. You can ask the patient, does it feel seated all the way down? You could take another thin layer of bite registration material or disclosing, like fit checkers, expensive for us, but you could put that in there, seat it in, press it down, and make sure that you had good denture contact to the tissue all the way around, and especially in that area where the keeper is. So you see here the holes have been initiated, or the recesses for the keepers. This white ring is your block out. If you've selected the keeper correctly, your ring will sit down on that. You put the metal housing on top of that, and the white part is touching the tissue, and that effectively blocks out all the way around, so you don't have to worry about acrylic running up and locking onto that gold locator abutment. You know your locator abutment height is correct. You put that white ring on there, you put the keeper on top of that. If that hurts the patient, blanches the tissue, and is pinching the mucosa, then clearly the abutment is too short. If you put an abutment on there, put the keeper on there, and you can see under, and all the way to the lingual, there's space underneath the keeper. You're not close to the tissue, your abutment's too tall. To get the right one, you might have to try a couple. So Miss Pat keeps a box full of different abutment heights. Hopefully if we have a selection that day, and you say, all right, the 3 is really too short, I'll use the 4. Instead of using bite registration, this dentist is using fit checker, which gives you probably a better read. It's thinner, but it's also a lot more expensive. Same idea. Fill the hole with your bite registration material, seat it. When you're done, you can say, yeah, I don't have a millimeter, 2 millimeters of acrylic here. I'd like at least a millimeter. That's way too thin. It might even be interfering. So we're going to mark that with a pencil. You can pull it out and then grind it with an acrylic burr. Get it so it's very passively seated. Once you do that, you will clean it with alcohol, and then whatever material that you use to pick up your attachments, you fill it in this slot in the recess that you've made. We're going to use a Voco Quick Up. They're using Triad here. Seat that in place. I have the patient, I don't have the patient bite down. I usually hold it myself. I find that the patient is very likely to move, or they may not bite down consistently, and that they're biting and opening and biting and opening, and I'm not going to get a good pickup. So I'd rather just put it in myself, hold it with my hands, and make sure that I have a good steady insertion of the prosthesis. After your material is cured, you can pick out that black retentive element, pop in your colored retentive element. I usually use the blues. These are a little more retentive than the blues, and then pop that back in the patient's mouth.
Locator, the versatile all-inclusive overdenture attachment system from Zest Anchors. For over 40 years, Zest Anchors has been a global leader in the design and manufacturing of overdenture attachments, pioneering self-aligning attachments that make it virtually impossible to improperly seat an overdenture. Zest Locator attachment features a unique, patented pivoting technology. The Locator's innovative ability to pivot increases the attachment's resiliency and tolerance for the high mastication forces an attachment must withstand, and allows it to compensate for the path of insertion, even with up to 40 degrees of divergence between implants. During seating, while the locator male pivots inside the denture cap, the system's self-aligning design centers the male on the attachment before engagement. These two actions in concert allow the locator to self-align into place, enabling patients to easily seat their overdenture without the need for accurate alignment and without causing damage to the attachment components. The locator system offers both locator males and extended range males, which are designed for maximum versatility in retention and angulation to suit each patient's needs. Locator males allow for insertion of the overdenture with up to 20 degrees of divergence between implants and are available with 1.5, 3, or 5 pounds of retention forces. Retention force can be evaluated chairside depending on patient preference for level of ease of insertion and removal. Extended range males allow for insertion of the overdenture with up to an extensive 40 degrees of divergence between implants and are available with 0, 1, 2, or 4 pounds of retention forces. Look closely at how the locator's pivoting action and self-aligning design allows the attachments to seat effortlessly. First, the rounded surface of the locator attachment allows the male to center on the attachment before engagement, so it can easily locate its proper position, while the locator male pivots inside the denture cap. These two actions in concert allow the locator to easily self-align into place. Once seated, the locator's dual retention feature provides a firm connection both inside and outside of the attachment, delivering twice the amount of retention surface area compared to other attachments. Also, once seated, the locator male remains in static contact with the attachment, while the denture cap, which is processed into the overdenture, has a full range of rotational movement over the male for a genuine resilient connection of the prosthesis without any resulting loss of retention. As the patient chews, the denture cap gently pivots over the male in any direction to accommodate the natural movements during occlusion and the pliancy of the soft tissue supporting the overdenture. This provides unmatched resiliency, allowing patients to chew normally without any worry of dislodgement or discomfort. Compare this with attachments that don't pivot. Without the pivoting action, the overdenture is locked in a static hold. As the patient is chewing, the attachment can easily disengage because of the opposing forces of occlusion. Both the locator's pivoting technology and its dual retention feature ensure long-lasting performance of the attachment, as shown by an independent laboratory test comparing the locator to the Stern ERA implant attachment during 60,000 cycles of function. The locator overdenture attachment system continues to be the #1 choice of clinicians worldwide. Patients the world over are enjoying an unprecedented quality of life without the worry of ill-fitting dentures. The locator attachment system, the simple solution.
This is the new tool used for the, not new now, but as the newer of the tools. This is your driver to insert or to torque the actual locator abutment. This is a tool to pull out old ones if you're replacing them. If you unscrew that, there's an insertion tool underneath it. Note the different pound of retention associated with both the extended range. This was the original, the green one, and then they came softer and softer. Now they have a 0 pounds. If you have more locators than you need, then you can definitely use a 0 pound retention or 1 pound retention, and it'll make a little resistance form there, but it won't add a lot of retention so the patient can't get it out. And in the with the dual retention elements, you have the 1.5, 3, and 5 pounds retention. I always start off with these because it's easy to move up in the retentive force and keep your patient happy if you need a little more retention. Or starting them, if you start off here, then they kind of think that's going to be the way it is forever, and you wind up not having enough in a couple years. It's really made to start here, and as the metal invariably wears, it's made to preferentially wear the retentive element, but the metal will wear also if you're chewing on it a million times a year, and then you can bump them up here and get more retention, which is really similar to the day you put it in. I like the Quick Up as a pickup material because the light cured tends to be weaker, and you can see here in these fracture samples that the separation of the light cured acrylic from the denture base shows where the weakness is. On this side, the fracture occurred through the pickup material, and you just get a stronger construct done that way, and you can increase it even a little more by silinating the metal housing, which we don't do typically. Most of the time though, we use a self-cure material. That could be a cold cure material like a repair resin, or the Quick Up also works well for us. When you're using this tool, it's designed with the plunger here in the tip of the tool, so you can get that thing off of there. So if you push this in, it's designed to push that into the center of the keeper. You have a patient that's had 6 months of use on these locators, and you need to change them out. It's their maintenance visit, for example. So you push that metal thing in there. It's got a real sharp edge to it. You put it in the keeper, slide it to the side, and you can pop it out. It kind of gets stuck on that on the tip. So if you take that, tighten it, that pushes the plunger out, and that will eject the retentive element or knock it off the end, so you can get it off of there without say cutting your fingers or whatever. I don't know, it's just the way it's designed to be used. So put it in, slide it to the side, pluck out the old retentive element, tighten it, that'll eject it, and then you can go on and do another one. I bring it up because if you have this thing tight and you're trying to grab one or try to pull one out, it won't because that little plunger is going to keep it from going in deep enough. So you have to have a gap when you pick it up. So have a little gap, pluck it out, plunge it, and then open it up again. If you take it all the way off, here's your seating tool to put in the new one. Like that. So we take out the old ones, put in the new one. There's the plunger. It's got a clear one on there, barely see it on the, insertion tool. Just pop that right in. Here's a gap. This is when you put that into the denture, that plunger is going to push inside of there, so you'll be able to pick it up. But this is the newer locator, the most recent version. It's a good abutment. We don't use it as much just because it's not as commonly known in the community. So if our patients go somewhere else and we want any dentist to be able to look at that and say, oh, it's a locator, I can repair it, fix it, whatever they need to do. So this is the Locator RTX, and it has some advantages. It's pink, and it has a greater ability to correct for implant angulation, and you don't need two different types. You don't need the regular insert and the extended range. You just have one that goes onto this. So it's gold, it's pink, not a big deal. You have to have a tool, you have to find it from Ms. Pat. This takes any standard hex, 050 hex. It corrects up to 20. This one corrects more, and it all comes as a single set, which is nice. So I bring it up here not because we need to talk about the RTX, but I just have a good slide series on these, a series of photographs. So here's the patient's dentures. So tooling is similar, but not exactly the same. So we're going to take out the healing abutments and then select our abutment height. This is the ridge we're working with and the dentures at the resident. I don't know if the resident made these or the patient came in with them, but we're going to use the proprietary chairside pickup system. This is made by Zest, and it has the recess burr. It just cuts the hole to accept the keeper. Undercut. This particular pickup material is mechanical, not chemical, so there's not a bond. So you have to make an undercut, much like you're doing an amalgam. And then the vent. And I like the vent. I actually prefer making a vent hole. The purpose of your vent hole is to allow some of your pickup material to escape. So if you put in too much pickup material without a vent hole, you'll do an unintentional relining. It'll go all across the ridge, and you're really not wanting to do that. If you don't have a vent hole, you say, I'm just going to use a little bit, then you wind up not putting in enough material and you don't pick it up. You pull out your denture and the keeper's still in the mouth, and so that's disappointing. So really you want to use enough material so you don't have to do it twice. The vent hole allows you to do that. So instead of spreading out along the integular surface of the denture, you simply cut this hole through the lingual surface of your denture, and then that will allow the excess to be expressed out the lingual, and you can just cut it off and polish it off on the linguals. Usually I'll use a vent hole. Other instrumentation will be a couple of acrylic burrs and then your polishing points as well. Here's your abutment packaged in one side and your keeper, others packaged in the other side. So this is kind of nice. You don't have to buy both or look for both. So you measure the abutment height, measure the crest of the tissue, order that height. 2 millimeters, order 2 millimeters. If your tissue height is 3 millimeter, order 3 millimeter abutment. You take this abutment with this hand driver, put it into place, roll it off, and now you have the abutment in place. This takes an 050 hex, so you don't have to go look for a special tool. Tighten it down, and then torque this to 30 Newton centimeters. The keepers come then in this package. Here's your pickup keeper, and then the different retentive elements with their different levels of retention. So now we're looking from the occlusal, obviously, at our two abutments. We're going to put the white blockout ring down, put the keeper on top. These look real good to me. If you had a gap, you would need to block that out. You definitely don't want to lock on your denture. These look like they're sealed nicely all the way around, but if you have a tissue that's uneven and it's down on this distal side, but you can see the gold of the locator abutment, in this case the pink of the RTX, then you would block that out. We use a little cool dam, or you could use Orsil block out material that I like as well. Okay, this looks pretty good. We can go ahead and then use the acrylic burr or this cutter to cut a recess into the denture. Again, if you're wondering where, just put a little bite registration material in there, and you can poke through with an explorer. It's thick, oh, it's real thin right there. I'll even it out or open it up just a little bit more. You might even see an interference where it's not. I think that's a void, but this is the right idea where you your denture is hitting somewhere up in here, and you could visualize that with your bite registration material. I know this is not all the way down because it's too thick, so we know it's hitting somewhere, so you mark and then relieve those areas that are high until the denture sets. As we said, you push it, it seats down, you know it's seated all the way. Get your chairside material in this case, or your Quick Up if you're in the clinic. Whatever your material is, the Voco Quick Up has a bonding agent, so clean and dry it. You could even use alcohol to clean it. Put your bonding agent on there, air dry it, and then you put your acrylic in there, and then that sets up over a few minutes. Same idea here. We're going to use an undercut, going to bleed the tip, and then use the precision tip here to place it in the holes. Have the patient sit down. This is a light or chemical cure, so you can set it there. After it's set up all the way, pull it out. Take out the processing inserts. Put in the retentive elements, and then you're ready to go. Maybe one suggestion, you put that locator in the first time, that new denture on 4 implants, and you snap it in. The patient says, oh, that's great. You should look at it and think, it's a little bit tight, but maybe we'll see how that goes, because you know it's going to drop off in 2 days, 3 days. The retention is really high at first, and then it drops off. So you don't want to say, oh, this is perfect. And then they'll come back in 3 days and say, now it's looser than it was on day 1, or a week later, it's looser than it was on day 1. So establish the idea that it's going to drop just a little bit, and then it'll be that way for several months until they come in for their recall appointment. So that's hopefully enough to get you started on inserting locators.